Britt DeVillier. Bonnie Hartstein. Charles Checkwith. Juan Juarez. Julie Lewis. Jorge Sainz. Sally Snow. Vern Walker.
Here.
And myself. We have 100% attendance. All right. So we start off with committee liaison reports. Air Medical. Jorge?
That's after.
Okay. EMS?
The EMS committee met February 9th at 2 o'clock. The main topic of discussion in there was about the need for medical direction control and the medical directors being more active with their services, and wanting to know whether there should be a change in their in the language of the rules to add to that. Then they adjourned that meeting and then opened up a joint meeting with cardiac medical directors and EMS, and the topic of discussion in that portion of the meeting was requiring national registry to stay certified in the state of Texas. And there was no resolution to that topic. They just continued to discuss it and back and forth. But
So were there specific, was there specific points of discussion regarding pediatrics within that?
not really.
All right, thank you. Education, Charles?
We had a meeting on April 13th of this year, and the major discussion that they were focused on was the transition course and how that's going to get rolled out. They're still working on it. Also, they talked about for research, removing one of the ways of doing research, and they are going to recommend that CCMP be removed from a way of doing the research. And they also talked about using National Registry CE hours listing rather than having a National Registry CE hours and a State of Texas CE hours. And looking at the CE hours that are listed for National Registry, it shows that the National Registry has 12 hours that would cover the pediatric stuff.
Was there a specific timeline that was discussed?
No timeline yet.
And is there a mechanism for the National Registry for the pediatric hours where we can look at content, or?
There's just a section on covering the different areas in the pediatric that's needed.
I know we have several people active in the state on that particular area. Okay, injury prevention, Deb?
Yeah, so really the only thing that pertained to pediatrics that they discussed yesterday was their strategic planning process has been put on hold based on the fact that the general GETAC committee is going to be working on a strategic plan, and they wanted the IP group to hold off until that was in process. So what they suggested for their committee was to try to determine in the meantime some injury prevention sort of focus for the state. And they presented quite a bit of data from the Whiskers database, which I believe is a CDC database, in looking at Texas compared to other states, and then Texas compared to the US numbers of mechanisms of injury that are leading to death in the state. And we've asked them to kind of repull that data and focus on having a pediatric set of data that we can compare versus an adult set of data, so that injury prevention programs around the state can really focus on the things that are killing our children and move forward with some of those programs. They're also going to address programs sort of in this focus, address programs that are evidence-based and that are working versus those that are not, that are sort of, your feel-good programs. So hopefully that will help move some of the injury prevention efforts in the state along. There's also, on June 20th through 22nd, the Texas Injury and Violence Prevention Conference will be here in Austin at Dell Children's, but it's sponsored by GETAC, DSHS, the Greater Dallas Injury Prevention Center, and a number of other centers. I'm leaving some off across the state, bringing in experts in the field of injury prevention from a national perspective so that we can learn best practices and things to implement in our facilities and organizations.
So it's great, and you made an interesting point that I think is cross-cutting from my question with Charles earlier, and that is specific types of injuries that we see in this state. Submersion injuries may be a much bigger issue here than they are in other states.
Right.
Which is sort of the same genre of occurrence for Washington State.
Absolutely.
And what drove Seattle.
Right.
So I'm just curious how much of that overlap and how much of
So in just sort of briefly looking at the presentation that they showed, for all ages, motor vehicle collision occupants and drownings, and for some reason that one was broken out between the ages of 1 and 4, had the highest incidence in Texas compared to the national data. And a few of the states that they pulled out, just as comparison by individual states, it was that way as well. So those may be two of the things that we obviously need to focus on.
I think the other thing that was noteworthy about that meeting was when we talked about breaking out age groups, it was the first opportunity that we had seen where our definition of pediatrics as the 15th birthday
Would have helped.
been applicable, and because those kids are not drivers, and that would tell us if they were injured as an occupant or if they were injured as a driver by that age breakdown. So it was
Yep.
nice to see that there was an opportunity to use that definition.
Right, great point, Sal.
medical directors. Juan?
They met yesterday. They had 11 items on their agenda, 3 of which were pertinent to pediatrics. The first of which, they tabled the discussion on the equipment list that was had a joint acceptance by ACEP, AAP, and Associate for EMS Physicians. They tabled it because that had been ongoing for the last several meetings, and they felt good not discussing it. Secondly, the development of guidelines, triage, and allocation of resources during catastrophic events and pandemics. There was an update for the audience and a presentation at the last GETAC meeting. And how this specifically pertains to pediatrics is 2 days ago, I think Dr. Laura Leftis from TCH had led a discussion on tweaking the adult and pediatric guidelines for ventilator-assisted patients. The thought here was that they wanted to create centers of excellence in the major metropolitan areas, and to where you couldn't get a 1-to-1 ventilator to patient ratio in most places. And so to have centers of excellence, you would hoard these ventilators there and have patients come there with the highest level of care. Noted was there was discussion in kind of the rural areas that this was not going to be possible, so there's still ongoing discussion about how to manage those types of areas. Thirdly,
So this is really in reference to special needs or?
Yes. During those crisis times. Thirdly, there was discussion on the impact of drug shortages on the Texas EMS providers, and that's certainly hit all our hospitals. There is no national solution at this point. There's a lot of local and regionalized solutions, the majority of which seem to agree that an agreement needs to be at a pharmacist level locally, at a hospital level, to kind of gather resources and divvy it up amongst various providers if there are extras from one side versus the other. That was discussion in addition from pharmacies and compound pharmacies. To bring that forward, again, there's no solution, at least 6 months to a year without a solution for these national drug shortages. So this is an ongoing thing that they will continue to look at, but that's the best type of solution that they came up with. Certainly this has hit the pediatric population as well. The 2 biggest drug players were going to be the benzos and the opioids. And that was all pertinent to pediatrics.
Great. Thank you. Questions for Juan? Stroke.
The stroke committee met yesterday afternoon and didn't have anything pertinent to the pediatric
trauma system. Sally?
I think I can talk about it without the microphone. There was a lot of action taken yesterday by the trauma committee. They have had a couple of additional meetings, including one on the 8th of May, where they made some good progress toward making recommendations for changes to Rule 157. Specifically, Scott Christopher presented some language on performance standards and events that was moved forward by the committee to GETAC. Dr. Daniels made some recommendations, or his group made some recommendations for language on non-boarded physicians. The trauma registry validation language was accepted and moved forward, and then new PI terminology specifically related to the use of the term preventable, non-preventable, or possibly preventable. The ACS has changed their language to include things like mortality without opportunity for improvement, and those are the kinds of things that were approved and moved forward. The Trauma Systems Committee has established liaisons for several groups, and those reports were not, there was no time to do that. There was also a discussion about the Texas Trauma Registry, and I think we have that on our agenda as well, so I'll cover that. But lots of action moved forward by that committee. Nothing specific to, I take that back, there was specific criteria for pediatrics suggested, and we've seen those before, so nothing seriously changed.
Rax?
The RAC chairs met yesterday evening. The biggest thing on the agenda was a presentation by the Assistant Director of Medicaid and CHIP on the Texas Healthcare Transformation and Quality Improvement Program. It was a discussion of the proposed regional healthcare partnership regions. Just to give a brief summary of that, this is dealing with what's called the 1115 waiver. The waiver goals are to expand risk-based managed care, support the development and maintenance of a coordinated care delivery system, improve outcomes while containing cost growth, protect and leverage financing to improve and prepare the healthcare infrastructure to increase access to services, transition to quality-based payment systems and managed care and hospital payments, and then provide a mechanism for investments in delivery system reform, including improved coordination of the current indigent care system in advance of healthcare reform. Some of the biggest discussions from the RACs were the fact that the healthcare partnership regions don't necessarily correspond to the RAC regions. There's a couple of RACs that have 3 healthcare partnerships in there. There's ongoing politics with the decisions for the anchor facilities, or the anchor, of the healthcare region. The anchor is allegedly supposed to be a public hospital, but if there is no public hospital available, then a medical school, teaching facility, or a private hospital could fill that role, and that's where there's some issues going on. This is actually a $29 billion funded 5-year program, and it is basically through the Medicaid. It has to be a Medicaid provider that receives these funds. So it's a huge positive because it actually exceeds the upper payment limit funding program. It's actually being phased out. So there is extra money there, but at the same time, there's a lot of logistics that we have to go through because CMS at the federal level has a lot of say-so in how this is developed. So it is a step forward for Medicaid managed care, which obviously Medicaid is a high proportion of pediatric payment in the state, but it also is dealing with the indigent care, and then there was issues about border cities, both the international border and other state borders, and if a system or a provider provides services to a population across the border, then that can be used as population data for this project. So there is no penalty for that service with that. So it was a very interesting conversation, and I believe if you go to the DISH's site on the, the HHSC site, they actually have all of this posted on there.
So just a question for Jane. I know that you sent out some information on the 1115 waiver webinar descriptions. I guess I would call them webinars. Is there a specific strategy for which GTAC is viewing discussions for the 1115 waiver. Clearly, it has huge implications with quality payment reform.
I don't believe so right now. This is so new and is rolling out. It is ever changing. And one of the things that she pointed out last night was that, you know, this is still in the development stage. It's a 5-year grant process. So we expect that some of the requirements of that grant may change over time. She actually, some of the questions that came from the RAC chairs, she could not respond to because she said that hadn't been determined by CMS. So some of they don't have all of the information on what the requirements will be. So I don't think GTAC has had an opportunity to develop any type of strategy.
Part of that also is the map that they rolled out in March is actually going to be revised next week. So everything is an ongoing process. You know, we're officially in the first year.
Meaning redefining the regions?
Yes, some of the regions have already been redefined, because this also includes your intergovernmental transfer agencies. So a lot of those agencies have input as to which region they want to be a part of. A lot of different counties, different things, not just hospitals or medical providers have input in that. So there's a lot of discussions going on for that.
Dr. Messias, one more comment. The North and South chapters of the Committee on Trauma for ACS for Texas, they did meet a couple of weeks ago in a joint meeting along with some members of Trauma Systems Committee to talk about the 1115 waiver and to come up with some proposed ideas at what could be incorporated into these plans specifically for trauma. And the individuals that were at that one meeting did take some of those suggestions and develop them and send them forward to the folks that are putting together the plans for this waiver. We don't know if those will be accepted or not. Last night at RAC Chairs, Dr. Ryan filled us in a little bit. He's been on the I guess the steering committee, for lack of a better term. I think it's called, is it Clinical Champion? Was that it? He's been on that group, and he said that when they helped develop some of these plans, that they were looking at having them extremely broad so that lots of different things could fit in under the categories that they had set up. And I think the Committee on Trauma, they were trying to look at it, distill it down, and make it more specific to trauma. So from that perspective, it wasn't really GTAC, but the trauma community, I guess, came together really quickly and gave feedback and input.
Thank you. That it makes sense. Obviously, the fear that we operate in silos through different regions without a cross-cutting metric and plan is there. So we certainly appreciate any updates. All right, disaster planning.
Yes, disaster planning met yesterday morning, and I was in communication with Eric Epley, who's the chairman of that subcommittee, and discussing what pediatric specific issues discussed. There were none specific to peds, although there are a few that we're continuing to monitor related to peds, which are mostly related to transportation and surge transportation planning, and making sure that there's pediatric specific transportation modalities, and safety is an issue in transporting children, and making sure that that's something we're looking at, and also in the social media usage, and making sure that reaching out to the right subgroups of the population. So got my eye on a few of the items on their agenda, and we'll continue to work that as we go into the next meeting.
And I assume that includes special needs as well.
And I want to make sure that's what I'm concerned about.
All right. Perfect. Any questions for Bonnie? All right. So we have an EMS for Children State Partnership update. Tony Gilchrist is at EMSC in DC, and Sally is presenting on his behalf.
He sent me a 5-page report, and I'm going to try really hard to do it in a timely manner. One of the important things that is coming up on the horizon for EMSC and for all of the country is a survey to look at national pediatric readiness. It's called the National Pediatric Readiness Project. It is a second round of surveys to look at all hospitals in the country, and about 6,000 of them will be surveyed, to look at pediatric readiness. This was done back in 2001 when the original guidelines for care of children in the emergency department came out. And there was a readiness score, a formula for determining readiness come up with at that time through a research project through EMSC. And this is a repeat of that survey, but a much more comprehensive survey that will give us a lot more information and a lot more opportunity to benchmark against other hospitals. It'll be a multi-year quality improvement project that measures the current capacity of emergency departments to provide immediate treatment and stabilization for children that seek emergency care. It is in alignment with the EMSC priorities regarding regionalization of care. It will address existing gaps in local, state, and federal resources. And it will allow hospitals to benchmark with hospital groups in like hospitals immediately and help you identify your strengths and weaknesses and provide access to quality improvement resources. So this is going to be a much more useful tool than the original survey. It's going to be completely done online. You can print it out and take it to your supply room and check off the equipment to see whether you've got it or not, and then go back and fill in the survey at a later date. It may take about an hour. It will be going to the emergency department nursing leader and physician leader, so hopefully that somebody will work on getting that done. Also, it looks like the EMSC project, especially here in Texas, has had some conversations with the Texas insurance industry, and they're very interested in the National Pediatric Readiness Project and the results of that. They're also very interested in regional systems of care for pediatrics because they think that it would reduce unnecessary transports, admissions, and repeated diagnostics, and they're very interested in partnering with the EMSC project to promote that. The Essential Pediatric Airway Project was done by the EMSC State Partnership Grant. There were BVMs, neonatal BVMs purchased and given to EMS 911 agencies that requested them. There were 220 BVMs, neonatal BVMs given out. There were 100 in-total CO2 detectors given out, pediatric sizes, and there was we were surprised that the request for those neonatal BVMs was so low. So there is still 50 AMBU bags and 400 neonatal masks available. So if you guys know EMS agencies, please take this information back to your RACs and let them know that this equipment is available. All they need to do is contact Tony at the EMSC State Partnership Grant and request that equipment. The Pediatric Continuing Education Program, the EMSC State Partnership Grant is currently working with the Office of Rural Health to develop some educational programs for rural areas through the critical access hospitals. This will be done with a flex grant. There's a proposal been submitted for a pilot partnership with Rankin County Hospital District and Upton County, which is centrally located in a cluster of several West Texas critical access hospitals and facilities. We're looking to maximize the impact with some low-cost CE for pre-hospital providers, perhaps the emergency pediatric care course that NAEMT has, or some homegrown product that EMSC State Partnership Grant develops. The biggest challenge is going to be being able to provide low-cost nursing CE as well as EMS CE at the same time with maybe the same course. And that may be impossible if we don't do something homegrown, so that's in the works. Certainly, we intend to keep the principles of evidence-based care, family-centered care, and medical home central in all the education that we develop or present. There were some online and offline pediatric medical direction surveys done. The original one was done by the MSC project in 2010. There was another survey done at the 2011 EMS conference. The results of that are available and quite lengthy. I don't know how much you want me to present of that. Do you want me to talk about this? Okay, at the next GETAC meeting, there will be a full presentation of these survey results, which really cuts down on the length of my report, and I'm so excited about that. Yeah, I think that's pretty much it. Any questions that I could take back to Tony about the EMSC State Partnership Grant?
Did any EMS service that's submitted for the BBMs and the masks get those BBMs and masks? I would assume yes, since we have extra.
Oh, yeah. Everybody that asked for them got them, yes. And there's still additional available, so. Okay, okay, I'll do that.
All right. We had a cancellation from Susan Rodriguez. She is ill, so we don't have a child fatality review team update today. But she assures me that we will have one at the next meeting, which brings us to agenda item number 5. This was a discussion that came up briefly last meeting on the definition for pediatric for trauma purposes, and this is the central discussion was really surrounding this was accepting a definition of less than 15 years of age for defining pediatrics for trauma. Part of the challenge the group had is that in concept we like the idea of endorsing, and in fact we endorsed with caveat that general concept, but wanted to have stipulations for the way that it would be applied. Part of the concern was that there may be circumstances in which it's forced into regulatory measures, and so we didn't want it to be so prescriptive that it drove the wrong kind of care. And so I sent a reminder for everyone to think about these specific issues in the domains of regulatory measures, clinical care recommendations, and educational initiatives. Jorge, did you want to start with some of the discussion that you had that you forwarded to me?
Sure. Working. When you send that email to Charles, last week, one of the things that we were mentioning is that, at least in our area, one of the in the part west of Texas and El Paso, we have two systems, or two big pediatric systems, and there's a couple of trauma centers that don't have extensive pediatric capabilities now. So when those patients, go to the other systems, our biggest fear was that pediatrics or specialist services would not be available for them to be taken care of. Although that happens fairly infrequently, if you have a 16-year-old, child or a 15-year-old child that requires a specific pediatrics or special services like pulmonology, infectious diseases, or cardiology, or all the services, those services might not be available in the other centers. So that was one of the major caveats that we were looking at. For research purposes, as statistical purposes, I really don't see any deleterious effect of having a cutoff of 15 years of age for statistical purposes. So it was just out there because our situation is a little bit different than everybody else as we're wrapping up with pediatric services in our city.
So if I could challenge you with the following thoughts. So as we apply quality improvement tenets in major systems of change, whether if you're looking at healthcare infrastructures, we often talk about a shared baseline, a common definition that is applied using a Pareto principle. So we have this shared baseline where 80% of the time we use that definition, but the finesse and the art of medicine is really crafting the other 20% for how we define it. So would it be reasonable for us to, and I'm just going to throw a statement out there for us to start to discuss, to endorse the general concept of age less than 15 years as a pediatric definition for statistical purposes, but for regulatory measures, clinical care recommendations, and educational initiatives, age cutoffs for defining pediatrics should not be so restrictive as to disregard differences in development, physiologic, emotional, and sociological, and such differences should be taken into consideration with programming and metrics so as to account for expected variations in these populations. So can we work along these lines to...
I'll move.
Would that be reasonable? I really did not want to override the discussion. I just wanted to give us a framework to start with. So, is it sufficient to cover those three domains, regulatory, clinical care, and educational? Are there other areas that need to be addressed where variations in the populations that we care for are going to be significantly different based on natural variation? Is that all inclusive? Okay. All right.
So moved. Yeah.
Well, do I have a motion to accept that as
And
a?
I'll second.
Okay.
We have a point of clarification.
Yes.
This has been an issue at every facility of affiliation with. You keep saying younger than 15. The trauma system's definition of a pediatric patient as of February 8th is 15 or younger. It includes a 15.
Oh, it's inclusive of the 15.
Inclusive of 15.
Oh, I had
If
it.
someone in the trauma system wants to be
No.
sure.
I think it's under
It's 15th birthday is the cutoff,
It's
right?
written
Yeah.
right, it says 15 years or younger.
Inclusive of 15.
Inclusive of 15.
Yeah, I agree.
Inclusive of age 15. So if you turn 16, you're not in this pediatric.
This is what our trauma system committee has adopted as of February 8th. So,
That's odd, because February 8th is when I got up and asked them to make a statement about it,
I
and
wonder if they
I
misunderstood.
understood it to be 15th birthday. 15th birthday made you an adult.
Yes.
Scott, is that right? The intent of the trauma committee. Wasn't it the intent of the, sorry about that. Wasn't it the intent of the trauma committee when you defined a pediatric patient at the February 8th GETAC meeting, that the cutoff would be the 15th birthday? So 15th birthday up was an adult.
That's my recollection, yeah.
Yeah, that's
Yeah.
what I thought.
It's,
this is
the
what's
documents
printed
are,
on the document.
Right.
So,
It says pediatric patient is defined as an individual that is 15 years or younger.
so that
Well,
would
that
include up to
includes
the
up to
That
16th.
includes up to the 16th birthday. So is this wording incorrect?
I don't know. Let me go back there and look at my notes. I got them on my computer from
Okay, it's
February.
that one that was posted on the
Okay,
website.
okay, I'm with you now.
Well,
I mean, it's kind of a moot point for our discussion.
well, no,
Clarification for-
it's important.
Right.
Right, it's important because if the intent of the trauma committee as well as this committee was to standardize along with the ACS definition, then we want it to look
Right.
exactly like that definition.
I'll look at it up back there, and by the time y'all get to open public comment or whatever, I'll have an answer for you.
Okay, thanks, Scott.
Great. Comment?
Okay.
Hi, I'm Lillian Lau. I'm one of the trauma surgeons and the pediatric trauma medical director at University Hospital in San Antonio. And the wording is exactly per the American College of Surgeons wording, which is 15 and younger for pediatrics. However, we at our center take that definition to mean, and it's solely for research purposes, because anybody who's sort of 18 and under we treat as a child for developmental purposes. The reason why the college said 15 is because sort of as far as size and the type of equipment you would need, a child around the age of 15 is adult size in terms of interventions that we would do. But we take that definition, 15 and under, to mean that the minute you turn 16, you're no longer in that pediatric research data collection process.
having Dave look.
So if we can clarify that as we move on to the next agenda item.
So we tabled the motion.
We've tabled the motion. We're going to come back to it after the open forum because you're exactly correct that this language needs to be accurate. All right, so. Discussion of pediatric imaging. Do you want to set the framework for that so I can get to this?
The last time we met, we looked at the Pennsylvania Trauma Systems Foundation position statement on use of radiation in children, and they had some recommendations for when there should be the pediatric low-dose radiation used. And we decided to come up with our own position statement, not necessarily copying theirs, but come up with our own. And we did have a draft put together by Dr. Macias and Dr. Ward at Texas Children's.
Who's a radiologist. So this is, again, based on the discussion that Sally initiated on minimizing ionizing radiation, just to set the framework for why we consider this an important issue. Some epidemiologic public health studies suggest that CT ionizing radiation, at least for abdominal CTs, given public health estimates, that there are about 500 cancer deaths for every 600,000 CTs done. So looking from a patient safety perspective where benefit really should outweigh risk, are we really looking as a state at strategies for minimizing ionizing radiation when it's not absolutely necessary for that to be done? So using the framework that the Pennsylvania group had come up with, we've drafted 5 critical elements that we think are strategies to propel a policy statement forward. What I would like to do, assuming that this is within the scope that we can do, and I turn to Jane to ask that strategy, is to discuss each of these 5 points, assign them back to members of this group to develop a brief 1 to 2 paragraphs, bring them back, aggregate them in our next meeting, and formulate a policy statement at that point that we can then take to GETAC. Is that a reasonable approach? Okay. Great. So point number 1, that all CT scans on children should be performed using pediatric dose reduction protocols, that pediatric protocols are available through the Alliance for Radiation Safety and Pediatric Imaging and are resources given from that radiologic society. Does that, can I hear discussion regarding that? Does that sound like a reasonable approach to minimizing, when necessary, this is presuming that CT is necessary at that point in time, that we would use pediatric dose reduction protocols? Okay. So who can we assign a brief on? And I've got a couple of resources for you with references, so I think
the purposes of my brief will be to kind of get a little bit more into the weeds with what that the resources for to suggest for what those protocols look like and
very general,
what they are.
not at a radiologist level, but
Okay.
to really give the providers in the state a recognition of where they can go to establish that their institutions have pediatric dose reduction protocols.
Right, so really giving them the references to go
Right.
to those sites to find those protocols, not so much to outline the protocol.
Right. And so 1 brief paragraph so we can aggregate that into our policy statement.
Charles, quick question.
Uh-huh.
Just in terms of the focus, we're trying to hit this at a state level. I know there are national movements that are hidden on a much broader level, and just make sure that we are in alignment with them. For example, the FDA just came out, I guess, 2 days ago, and recommended that all future CT scanning equipment would have kind of a 4-stage pediatric dosing up to adult inherently built in. Of course, it couldn't be applied retroactively, but you know, the FDA and other kind of oversight organizations, we should make sure that our wording is in alignment, not just at a state level.
I'd agree, and so I would encourage members of the group as we craft this policy to look both at ALARA, as low as is reasonably acceptable, movements as well as image, what is it, image gently, image soft, image gently, policy movements as well, so that they are consistent with that language. So absolutely, and especially with recent strategies, I think it's good to be able to reference that. So number 2 is imaging modalities that do not use ionizing radiation should be used when feasible. The example of that is encouraging ultrasound use instead of CT for the evaluation of appendicitis in children. Do we consider this to be a reasonable recommendation to set forth? So what we posted was some discussion of the use of clinical decision rules that scientifically give us very good predictor models where we can translate much of that, much of the clinical presentation, as well as ultrasound to make those diagnoses. So can we assign that to someone? Someone willing to take that paragraph? We do not. Oh, perfect. Again, I'll send out references in the Pennsylvania statement as well. Number 3, avoidance of the use of protocols which automatically result in the performance of multiple CT scans, i.e. head, cervical, spine, chest, and abdomen and pelvis in pediatric trauma patients. Do we agree with that recommendation? And we certainly would encourage members of the audience to chime in. All right, is that then something that one of the members of this group would like to take on? Number 4, avoid further CT imaging once the decision to transfer to definitive care is made unless the accepting institution specifically requests a scan prior to transfer. If CT imaging is performed prior to transfer, the images should be included in the transfer documentation on disk or some other form of reviewable file. The final radiology report should be forwarded to the receiving facility via fax or electronic means as soon as possible. Do we believe in this recommendation? Okay. Someone want to take that one on?
I would say maybe add a little caveat or transfer is delayed for some. Not the imaging.
Well, and it needs to be appropriate imaging too, because one of the things we've had problems with is outlying hospitals doing abdominal CTs on kids without contrast. And then that study's no good to us, but we don't want to re-image them for further exposure. So maybe that's the reason I volunteer to do that, was because we throw that in as well.
Number 5, accepting institution should avoid repeating scans. Should those go hand in hand with 1?
Yeah, I was going to say 4 and 5 goes together, but I'll top of 5.
Okay.
Have resources where we can.
All right, so your homework.
You know, I guess that's a question that I had when I was reading about that point. How do other institutions assimilate that data into their system? Say, for example, you send a CT scan from an outlier facility that we read, you know, the radiologists read. How do we accommodate that into the medical record? You know, this is paraphrasing what somebody told us. How do you make it?
So I think that presents one of the needs assessments, that it's the lack of comfort with accepting an outside radiology reading that often drives re-imaging, and if in fact the strategy circumvents that from the very beginning by saying we really don't need the reading as much as we need the actual images, so that our radiologists that are providing definitive care in this institution, at this tertiary center.
But that brings a unique technological issue in the sense that it used to be that the DICOM viewer to read outside disk was in the teens. Now it's in the hundreds. So you have to be equipped locally with different kind of viewers nowadays to make sure that you can encompass reading. If you have a base population, base area that gives you 40 different types of CDs or DVDs, you have to make sure that one, that you can view them, or 2, that it can be incorporated into your PAC system. So
So perhaps, so then one might even envision this as a baseline recommendation with a strategy that perhaps with a state partnership or the Children's Hospital Association of Texas, we can push forward to a standardization of a
Yes.
smaller number of tools?
Hi. I think I have an answer for both of your questions. At our institution, we are the major referral center for South Texas. And so what we get are 20 million different types of scanner discs, and we used to have a problem with that in viewing most of those images. And because of that problem, we actually acquired a technology called Life Image. And on Life Image, what happens is you can load the discs from different scanner like machines onto this website basically that is HIPAA regulated and all of that. It's login required, and we're able to load all of our trauma transfer discs onto that imaging system so that everybody in the hospital has now essentially image capabilities to view the outside images. And the qualities from our perspective are no different than when we open up the discs and look at each individual disc from their own programming, but it allows all the different specialties to look at the images that they need to look at. We're also looking at the quality of those image transfers, because at this point we're looking at it. If there's a question, we'll do further imaging as far as ultrasound, MRI, whatever, rather than another CT scan. But our radiologists are not overreading those films because of the medical legal issue related to that. We're getting the final reports from the outside institution, but that's how our institution's dealing with it.
So do you have specific data for decrease in CT re-imaging since you implemented that? It'd be great to have very specific data to include.
We are looking at it because we started Life Image in July of 2011, and so this is a relatively new process for us, and we're trying to decide if we're officially going to buy this product for the hospital for a longer contract. And so I think our data, we can have some reasonable data within a year of saying how much we've decreased imaging, not just for children, but also for adults.
Okay,
Question,
perfect.
does that just allow you to load the disk into the internet and then see it? But say, for example, they scan them and they send a partial file or no file at all.
So what we're working on is actually having some of our referral facilities actually also, because if we buy it such that other users can use it outside of our facility because it's an internet loading, they can load the images and we can view it almost instantly. From our facility, that serves two purposes. One is we make sure that that image is completely loaded before the child is transferred. And second, it's that if there's any major interventions, for example, an epidural or a subdural that needs to be evacuated and a child's coming, then we can have our teams ready and everything before the child actually lands.
We just have implemented Life Image at our hospital as well, and we have a pilot going with one of our referral facilities, and I think it's really going to be an awesome product, and we're planning on putting all our referral facilities, 30 or 40 hospitals, on it. And I know that the STRAC is also looking at helping with that because it's the same rep that is coming down here that has come to our place. And it's a really awesome product. I'd encourage everybody to look at it. And the thing, one of the points you made is that you can look at those images before the patient ever gets to you, so you can have your teams ready and know whether that's something you need to do or not.
It's our facility at least, we don't mobilize people to research images. That you could mention. So say, we don't mobilize the neurosurgical team, you know, to receive the images for epidurals and things like that. But that would potentially be able to save lives.
Absolutely. Boston Children's has it, and they have several instances where they have saved lives with it, just under those circumstances.
There are a number of states that have implemented these programs statewide. Arkansas is one that they require every hospital in the state to be part of their linked system where they're able to transmit images, and it has saved lives in mobilizing teams and whatnot.
I'm going to take that as a volunteer effort to join Juan in that statement.
That's great. I'll be glad.
Sally, I have a question for you. Over here. Ooh, over here. Is this initiative part of the Health Information Exchange that is developing the HIEs? Do you know? Or is it strictly located at your hospital? It's a hospital initiative versus an HIE initiative?
Right now, it's a hospital initiative.
Okay.
And we're working with, our radiology department has an IT guy.
Mhm.
And so they have, LifeImage has all of the security documents that you need to assure your compliance officers that it is a secure cloud and that there's no HIPAA issues at all. They're a great company to work with. And I'm not getting paid to say that.
And then from a national level, the Society for whatever the Radiological Society is, they've been in works on current studies with a cloud-based system that's actually free. They just piloted, and a lot of the regional and local radiographic kind of centers are starting to look at and see cloud technology. So there are some free products, and there's some, obviously products that require a large number of resources thrown at it. So the movement is there, even on the national level.
Yeah, and I think the important thing is really to describe the conceptual model rather than the proprietary
Yes.
programs, and so we just need to be cautious that that's how we approach it. All right, any other thoughts with our 5 recommendations?
I just want to add something from the transport world side of it. Although I agree that we need to look at keeping exposure down, totally agree with that. My concern is how it's rolled out, especially the rural facilities that maybe don't have that equipment or able to do that immediate transfer of scans, that the patients have a prolonged transfer waiting on. I just don't want them to get the wrong feeling about being able to transfer those patients, because bottom line, we still need to be getting to definitive care quickly. So I think that's just something we need to kind of put in the back of our minds and make sure that that's not a concern.
Yeah, and it's reasonable, because this is a quality improvement initiative, to describe those balance metrics too within the policy statement, to say, but be cautious that you measure these elements so that you're not delaying care. All right, well, that being the case, I am going to send that information out. We'll readdress the construct of that policy statement and hopefully have a definitive statement for GETAC to endorse at our next meeting.
And Charles, do you want these in a couple weeks to kind of then send it out and vet to the group, or?
Yes,
Okay.
yes. The final vetting will be with public feedback, but we'll send out about a 4-week deadline.
Okay.
All right, so we had a point of discussion here, agenda item that was tracking pediatric-specific trauma data and requesting clinically relevant data. And what that really was speaking to, and I'm not sure that this is probably the right agenda item for this meeting at this point in time, was what we really wanted to see from the older pediatric registry. What was age specific, what were the data elements. Where a lot of this discussion came about is recognizing that we didn't have a lot of good, or I shouldn't say good, we didn't have a lot of usable morbidity or mortality data because we'd not crafted those requests from what data existed. Where are we in the current process for the registry to finalize age groups and the way that all the data elements will be laid out? Is that completely done?
The registry is here, and they're going to update you on the process of developing the new registry. So they're actually the next agenda item.
So we can postpone the discussion on what we want from the old registry then till after that. So why don't we just move on to that and then come
Okay.
back to this agenda item?
Charles, for sake of time, I don't know if I did find the verbiage from the ACS.
Oh, perfect.
And in their frequently asked questions, it says, age limits for patient transfer triage should be defined by local community standards as written in EMS system policy. However, the Verification Review Committee of the American College of Surgeons will use less than 15 years of age for the definition of a child solely for the volume performance criteria during the visit. So that's pertaining to their verification site visit.
Scott, did you want to add something?
Yeah, both reading what the trauma systems did in February and also looking at it again on the webcast archive, it's pretty clear that the trauma systems bunch meant 14 years, 364 days old, you're a pediatric patient. When you hit your 15th birthday, you're an adult. So we do have a discrepancy between what they passed and I think submitted to GETAC on that Friday and this proposed language on this pediatric additional criteria. So we'll need to make, I'll bring this before trauma systems in August, make that note, and we'll get that changed.
Okay, and I think we'll then keep the definition that we used, which was endorse the general concept of age less than 15 years, or 15th birthday?
15th birthday is the key language, I think, so I think we'll tend to focus on that. So we're good?
Perfect. Oh, so then that becomes a motion then. So given that, let me reread the statement, that the Pediatrics Committee endorses the general concept of age less than 15th birthday as a pediatric definition for statistical purposes. For regulatory measures, clinical care recommendations, and educational initiatives, age cutoffs for defining pediatrics should not be so restrictive so as to disregard differences in developmental, psychological, emotional, and sociological, and such differences should be taken into consideration with programming and metrics so as to account for expected variations in these populations. Do we have a motion? Second?
Yes.
All in favor?
Aye.
Thank you. So we are now ready for our trauma registry discussion.
Thank you. Good morning. My name is Rob Klein. I am the project manager for the Trauma Systems Registry, and I'll take you through the next few slides here for this presentation. The manager for the Trauma Systems, DSHS Trauma Systems Group, could not make it this morning, so I'll do my best to take you through the entire registry, where we're at and where we're going. So today I'd just kind of like to update the GETAC members and stakeholders on the status, kind of the activities that we're going forward and where we're at currently with the project. We'll kind of take a quarterly view of our EMS trauma system implementation, and we'll kind of take you through the project activities of the next year. We are proposing some EMS trauma system demonstration dates, and at the end of these slides, we'll have some proposed dates for you, and we can discuss those further. First of all, I want to say that we're making great progress on the project, and a major reason for this is the stakeholders and their stakeholders' input. So I'd first like to thank all the stakeholders, both EMS and hospitals, across the state who have participated in the DSHS webinars. We look forward to your responses and input to our system demonstrations, which we are going to schedule for June. So thank you. And also I want to thank the members of the RSWG who have volunteered numerous hours to meet with us and have provided their valuable expertise in building the new registry. We look forward to your continued collaboration, and we welcome additional volunteers to join us as we continue to build the next components. It is your key input that's going to make this registry what you desire and what you need. We work with a vendor called Consilience, and we have daily sessions with them. Consilience has become an invaluable partner in developing the EMS trauma registry. We have forged an excellent working relationship with them, and they are very knowledgeable and help us immensely in working through some of the development issues that we've come up with. Current accomplishments to date: we have completed the trauma modeling phase. It was a large undertaking, and we have now completed the data mapping from the current registry to the new. A key part of this model does include the NEMSIS 3.1 data elements. A database migration interface component has been developed, and currently we are doing a data migration testing, and we're working through that process. There are a number of project activities that are scheduled over the next 4 quarters. We plan on going live in September of this year. And so I would like to now take you through the schedule and provide you an update on the activities currently underway. First of all, we'll talk about the second quarter of 2012, which we're presently in. We are currently doing our database conversion. We have over 22 million records to be converted to the new data model. So this has taken our old system and moved it to the new system, and we have approximately 2.7 million hospital records and about over 16 million EMS records. And this is also including NEMSIS and NTDB standards. So we are including all the standards that we have talked to our RSWG group. We've got input and feedback from them, and we are building the model based on this. We are also building a hospital EMS import interface. Now, this import interface will allow the hospitals and EMS who do batch or upload data on a regular basis to continue that process. So there's no changes required to your data at all at this point in time. We have built the interface to take your existing data import and be able to upload it into the new model. So there's no changes to this. This gives us time to take a look at any new data streams that we have to take a look at, and helps let you get your vendors or your applications up to date as we proceed to the new data model, that we can take that directly in. So that's still under working with RSWG. We're still working through that process. There's lots of work around that. We've heard back during this GETAC conference that there are some issues and we need a data dictionary and those type of things. We've heard you, we're working through that, and so we will continue that process. Around that, we also are working with some validation rules and conditions. As you know, we are working towards the NTDB and NEMSIS data element rules, and we are trying to apply those questions and how we will validate those rules all within the new trauma registry. We are working with RSWG right now and our groups and stakeholders like yourselves in making sure those rules fit what we need to work with the data, and we're continuing to work with that, and we will be having webinars and continuing working sessions to make sure we get the validation rules and conditions correct. So that's a continuing process, and we'll be working through that over the next month. We also have heard that this group and many other groups in RSWG are interested in trauma system demonstrations. So we're working through that, and we're putting together a session with our vendor Consilience. We're still working through how we're going to put that together, but we kind of have those scheduled for sometime in June. So second quarter is underway, and we're putting all the basic elements in place. Third quarter, through July through September, we have a very busy schedule. And our whole goal for this period is to get to right at the bottom there, that system rollout. So we want to be able to go statewide before the end of the third quarter. And getting there, there's a number of activities that we have to do, and there's lots of work. First of all, we have to move all of the user accounts from the old system or user registry users over from the old system to the new. There are over 1,100 hospital registry users and over 3,100 EMS registry users. So we will, when we go live, all these users that are in the existing system will be pre-populated. So we'll move all of your roles and groups over to the new system. There won't be anything that you have to do at that point in time. You'll be able to have your same users on the old system now implemented in the new system. So that's going to be part of Go Live. We are also going to do some training for you. So before we go live, we're going to have webinars. We're going to have them set up so that we'll take you through the system and take you through how the process of uploading data files, If you go onto the system directly, we'll give you that training and go through the different rules and validation points so you can get your data into the system. There will be an opportunity for selected facilities to pilot test the system. Now, they will be our final checkpoint to make sure the system operates as we need it to, and it'll just be our final check before we go live. A key partner with us has been TxDOT, and what we're looking to do with TxDOT is to create the ability to import crash records into the trauma registry. TxDOT has been a very important public health partner in the prevention of motor vehicle-related injuries, and in Texas, the leading cause of injury death is motor vehicle-related. So our goal is to link the crash data with the trauma registry data and use the analysis of the data in our prevention efforts. So that TxDOT interface will be built, and it will not be in place before we go live. So these are some of our key activities that we're going to take place during third quarter. Fourth quarter is a continuation of the system. Even after we go live, there are going to be certain components that we're still going to need to build. It's not going to be everything laid out to you all at once. So during fourth quarter, we're going to be doing some customized reporting. The system does come with some core components. It does have some ad hoc reporting that you yourselves can build within the system, and we will have some also canned reports also built within it also, some key reports. The issue we're going to have, though, is that we just don't want to take whatever's in the current system and move it to the new system. We want to go through our stakeholders, listen to your priorities, listen to what your reporting concerns are, and build those reports properly so you get what you need. So we want to take a step further and build some customized reporting, and through yourselves and our RSWG, work through that and set our priorities what those should be. And we plan on having those built during the fourth quarter. We've started the process now. We've got some input back from you. We need additional input, so we'll continue working that for the next few months here, so that when we go to our customized reporting, you'll get what you need and not just some canned reports that are sitting there that you're never going to use. So we want to make sure we maximize our reporting function.
So can you help me with a little bit of that language understanding, how that is operationalizable? So taking the perspective of this committee being the end user, we want to know specifically data related to submersion injuries in a certain age.
It's not going to be in the trauma registry.
Well, motor vehicle crashes,
Okay.
collisions, what we just discussed actually from the prior report.
Okay.
How would we interface with the group, and what makes that an ad hoc report? What is the process we're taking?
We would probably look at what type reporting you would require, like if you're looking at crash records, can we do that within the system itself and look at the data elements that you require to get that data? Now, looking at that, we can say, can we basically build a report within it and just go and do an ad hoc reporting and do that? Or do we need to build a customized report for you and get that built through our vendor, because we have that built into our plan, and say, this is one of the priorities from your group. We need this report to build it on crash data. Can we get this crash data out for injury related to your pediatrics? So we would look at that, and because there are going to be other groups like yourselves, you're going to want similar types of data, and so we're going to try to tie those together and bring them back to you. The other key thing that you should understand also is that you're going to be able to pull data from the system. So there'll be like an Excel file type of thing where you can pull your own data that you require to take a look at, and you'll be able to manipulate any way you want with any reporting systems that you may have yourselves. So there'll also be that piece in there.
And what constitutes that end user? Would the EMSC state partnership, for example?
Basically right now they will be part of the of if you're an end user in the system. So if you're hospital EMS in there right now.
So you have to be somebody who's sending data to get data.
Right now, yes. You can, though, put a request in through the trauma group in DSHS and ask for data, and they can turn that around for you and get that data back to you.
And you don't have to be a participating facility submitting that data?
I do not believe you do. I'd have to get further confirmation on that.
It seems to me like yesterday Tammy said
Yeah.
there were some canned public reports that were available.
That we have currently?
No, she said in the new system.
In the new system,
I
we
thought
do
she
have
said in
some,
the
yes,
trauma
there
system
will be
system.
some currently canned reports in the new system also.
Can I make a suggestion? Because I think it's extremely helpful to people who are not submitting data that need that data,
Okay.
like the EMSC group in the state, the injury prevention collaboratives that are throughout the state, is to do something like the CDC has done in developing sort of a portal on the web that anybody can go in and say, all right, for this region, I want to know what the, for ages 1 to 5, what the mechanisms of injury are most prevalent in the registry, which ones are killing most of our children, so that anybody can pull that data. I think it's vitally important that people beyond the end users get that information or are able to access that information.
I think the other great model that's out there for that public access is the HCUP, Healthcare Utilization Project the Agency for Healthcare Research and Quality has for all 7 of their sub-data sets.
Okay.
Amazing public access.
Okay.
Would love to see something like that.
We will check into that. And listen, we are interested in this feedback, so this is very good feedback for us. It gives us another avenue. There are a lot of things that are happening, so we'll continue putting these into our priority list and working through it. One of the other key things we are building is a registry enrollment portal. So right now, when you have to, a new facility comes on board, or if you want to make changes within your user groups or your facilities, as for your roles that for end users, it can be you have to go through a manual process at this point in time. Well, one of the key things we're doing is as new facilities come on board, they will be able to self-register. So this process will allow them to come in, ask for an account, an administrative account, come in and take care of that, add new users, and also we have a number of end user agreements, and we're working through that and making those automated. So those groups will be able to actually come in, get validated by DSHS staff, and then process that through themselves. So it's going to be a lot easier to get into the system and get access to it a lot quicker. And then we'll have also built in there a training sessions in there, so that each person that goes through the system will also, as they're registered, they will also be able to get the training they require just in time. So it's a real key piece. It won't be ready till the 4th quarter, but all of our existing EMS and hospitals and people users in the system now will already be pre-populated before we go live, so it will not impact any of our go live schedule. And then no project just ends after you go live. So we're going to continue working with our stakeholders. We're going to listen to them through the 2nd, 3rd, and 4th quarters. This is an ongoing process. We just don't drop it off. We are going to get user feedback and your experiences with the new system, and we want to learn what works and what doesn't. And also with any new system, there's always some requirements or some components that the users feel that they need or they want changed. So we're going to take a look at that. We're going to do an analysis of that data. We're going to look at our stakeholder priorities, and from that, we're going to take a look and see what we can build for enhanced version 2. And this will be a continuing process as we build this registry forward. So in ending, I just want to give you an update on our registry demonstrations. We have some proposed dates around June 5th and June 7th. June 5th is an afternoon session, and June 7th is a morning, to make sure we can maximize our participation. We are trying to set up where we can actually get some on-site area where we're going to have people actually attend and do things, plus have a webinar for that. We're working out through what the logistics of that will be, so we'd like your feedback on this, and we look forward to working with you in making this trauma registry system the best we can. Any questions?
The current set of data elements that you track, they're set in there for this first phase. The future data elements, say if it were requested and it was a broad range request, how do those get incorporated? Would that be with future versions or ad hoc periodically?
Well, there's a real, over the past week here, we've really been discussing that, what data elements do we really require? And it's come to us that, do we want to solely have NTTB requirements, just, the national ones to come through? Or is there another subset of elements that we've already have in the system? We want those captured also. And I believe we were going to start working through our registry work group to kind of start looking at that. That came up yesterday in a meeting where we're going to try to look at pulling together what that data dictionary looks like. We're trying to get a committee together on that, get that kind of future plan, take a look at, because a lot of the hospitals and EMS units have their own registry providers at this point, their own vendors. And because of that, they're looking at what changes do they want to make as they go forward, and they can tie into this new registry from the state. So we're working through that. We've listened to what is required, and we'll be setting up those working groups to get this put in place before we go live. Actually, the committee wanted to get it placed before the end of June. So we've got a lot of work to do, and we're going to work through those look through those data elements and get that put in place. So although it's something we should have had already, we're looking forward to actually, we have some stakeholder involvement now, and I think through that we can get a consensus on what those data elements should be.
Any other questions? All right, thank you.
Thank you.
We have one agenda item that was added to our agenda, which says discuss change of ownership implications to a facility that is a designated trauma facility. No idea what that means.
Okay, I will tell you about it. Okay, so when a facility that's currently a designated trauma facility changes ownership, the designation does not transfer to the new owner. So a facility that is under, and actually I should include and let you know that a physical location change falls under that as well. So the new location does not carry the designation from the old location. So a facility that has a new location or a new ownership has a couple of options. One is to reapply in active pursuit status, which means the facility files a letter of intent with the department with intent to apply for designation. Entering that status gains them funding eligibility for the next funding application, and that goes for uncompensated trauma care funding as well as other state funding as well, that where a facility has to either be a designated trauma facility or in active pursuit of designation. With that eligibility comes the requirement to designate in 2 years from the date they enter in active pursuit of designation. And with that, questions have come from RAC membership about transport protocols and participation in the trauma system when they're not a designated facility. And as has been for a while, any other facilities who have entered in active pursuit of designation, that is not to affect their participation and RAC transport protocols. So it could continue at the new location or with the new ownership as it had. And we just wanted to make that clarification and let you all know.
Great, thank you.
Mm-hmm.
Also, this does apply to stroke designation also.
It does apply to a facility that has a change of ownership that's a stroke facility. However, in active pursuit does not apply because there's no funding for that eligibility for funding there. A level 2 stroke facility can reapply and pay the $100 application fee, and then assuming that Joint Commissioner DNV certification still stands with the new ownership or new location, then we would then designate them as we do with a new applicant anyway. Level 3 support stroke facilities would have to reapply and go through the full application and survey process with TTAF.
One more thing, I'm sorry. Could you explain the DISPO rule change that was mentioned in the RAC?
Yes, I can. Okay. In the late calendar year of 2011 or this year of 2012, we're not real sure when it actually went into effect, but the HHSC disproportionate share hospital funding rule did undergo a change that said that for a facility to meet the trauma condition of participation to receive that funding, the facility has to either be now in active pursuit of designation or designated. Before, a facility had a 6-year stepwise process that they could, as long as they met each consecutive year's requirement, they would be eligible for that funding. So this is effective now and will affect the FY13 disproportionate share funding, and we'll be getting that list from HHSC sometime this calendar year, and then report to them if facilities have met that condition, being in active pursuit or designated. Mm-hmm. Thank you.
Great, thanks. All right, so we've got a few minutes left. We open this up for any public comment, any concerns, discussion points?
Good morning. I'm Christine Reeves. I'm the Executive Director for Heart of Texas RAC out of Waco. And a couple years ago, Charles brought forward the emergency guidelines for schools from Florida, North Dakota, a couple of them. Hot RAC, in collaboration with our Education Service Center and a local electric cooperative, has printed and will be training school districts all over our region to use a guide. Almost the identical guide with Texas changes to it. So I thought I would let y'all know.
Great, thank you.
You're welcome.
Is there a link to those that?
It's not posted to our website yet. I need to do the trainings first, and they take place in June, and then we will post the guidelines on our website, hotrac.org.
Any other public comment? Great. That then almost concludes our meeting. Just a review of charges. We have, for the EMSC report in the next meeting, a focus on 2 elements. One is online and offline medical direction surveys, and the other is a full report on pre-hospital protocols. We should have a new update on the child fatality review team. We'll bring the definition of pediatrics for trauma purposes back to the big GETAC meeting. We have our charges independently for pediatric imaging position statement that we will have completed at our next meeting. We will be looking forward to some feedback from the Registry Solutions group on these public access models. That is all I have. So thank you very much. This concludes our meeting.